In this video, we'll be talking about adrenaline in anaphylaxis. All I would say about anaphylaxis is that it is a severe life-threatening systemic or generalized type 1 hypersensitivity reaction, always sudden on onset and characterized by life-threatening airway, breathing and circulatory problems, often associated with mucosal or skin changes. You can remember this as ABC miss. Mucosal or skin changes are not enough to stamp a severe anaphylactic reaction, because mucosal or skin changes like urticaria or angioedema can be simply treated by pushing antihistaminics like chlorpheniramine. Patient should have every problem and should be presented with stridor or wheezes and should have circulatory collapse, and then only you require adrenaline. Do not push adrenaline unnecessarily by simply if a patient have urticaria or angioedema. So if you have a patient, right, and patient will present with skin rashes all over the body, around 80% of the patient will have skin rashes in the anaphylactic reaction. So the number one thing is skin rashes, or it can be urticaria, also called urticaria. A patient will have or may have angioedema. The most important thing is bronchospasm, and patient will have very low blood pressure due to vasodilation, and that is due to histamine released by mast cell. So patient will have low blood pressure, and patient may sometimes be confused or mentally disabled. So these are the conditions which would stamp that patient is having anaphylactic reaction. And these reaction, and to confirm the patient is having anaphylactic reaction, the best way is to know that the patient was exposed to previously exposed allergic substance, like a patient was exposed to previously sensitized penicillin or previously sensitized peanut or a walnut, or some patient may even have allergy to milk. So to confirm the anaphylactic reaction, the most important thing is that you confirm that patient is exposed to previously sensitized allergen. So to know that patient is having anaphylaxis, the patient should have airway, breathing and circulatory problem, and often associated with skin and mucosal changes. And the thing is that it should be always sudden in onset. All you got to do is push adrenaline, establish the airway, provide high flow of oxygen, and give IV challenge, and of course treat it with antihistaminics like chlorpheniramine and give steroids like hydrocortisone. The question is, why do we push adrenaline in anaphylactic reaction? And adrenaline works on alpha 1, beta 1 and beta 2 receptors. Alpha 1 receptors will do vasoconstriction, so it will increase total peripheral resistance, and finally the blood pressure would improve. By acting on beta 1, it would give positive chronotropic and inotropic effect, so it would stimulate the heart rate, and finally the blood pressure. And by acting on beta 2, it would dilate the bronchial tree. So this is the way why do we give adrenaline, and we'll talk about dose and dosage form of adrenaline in the next video. Thanks for watching.